Hello, everybody. Thank you so much for joining us today. My name is Nicole Lamberson. I was trained as a physician assistant, and I work doing outreach for the film Medicating Normal, and I also host conversations like this one today. Our guest today is Dr. Mark Leeds. Dr. Leeds is an osteopathic physician with a focus on medication-assisted treatment for opioid addiction and alcoholism. In addition to practicing medicine, he is the host of a podcast, The Rehab, on the Mental Health News Radio Network, and he currently serves on the board of the Digital Tech Initiative, supporting the treatment, research, and awareness of digital media addictions. Dr. Leeds also provides concierge private benzodiazepine withdrawal services. We'll put some of the links to Dr. Leeds' website, his podcast, where you can find him on Twitter and that sort of thing in the comments section for anybody watching today. So welcome, Dr. Leeds. Thank you for joining us. And I guess to get started, did I leave anything out of your bio that you'd like to talk about? I know you also saw the film, so if you have any words to say about that, certainly.
Oh, yeah, thank you for having me. Thank you for inviting me here. Yeah, the film was excellent. Thank you. And the film, yeah. I really enjoyed it. I found it very informative and interesting, and a great way to cover the subject and inform people on the dangers of psych medications. And they're definitely not for everybody. I think we're definitely in a situation where, the public is over-medicated to a degree because doctors are, we do tend to medicate people, to medicate problems. When a person starts describing a problem in a doctor's office, the first thought from the doctor in their mind is, what medication can I prescribe for this problem? How can I write a prescription? Especially in busy practices where doctors are expected to go in and out of a room every so many minutes, 10, 15 minutes. And their first thought may be, when they walk into a room to see a patient, how am I going to get out of here? What's the exit strategy? And that may be writing a prescription and saying, here's a piece of paper, take that to your pharmacist and let me know in a couple of weeks if it helps. And that prescription may be for an antidepressant or an anti-anxiety medication, and something that may in the short term seem like it's helping. But there's never really a long discussion over the long-term potential consequences of that medication.
Yeah, exactly. Okay, so maybe jump right into questions. I can't remember how we found you, but I think it was like a press release about that you were offering these benzodiazepine withdrawal services in Florida. So the first thing we did is we looked at your Google reviews, which is what everybody does, right? And they were really good. So I figured you must be doing something right because you have really good reviews from patients. And then we reached out to you, and then came on your podcast, Lynn and I, Lynn, the filmmaker of Medicating Normal, and myself. And then we wanted to invite you because I had some questions. Basically, like, how did you become interested in benzodiazepine withdrawal and the issues surrounding benzos to begin with? And who taught you about these issues? Were you self-taught, or did you learn in medical school?
It's more self-taught on the job. A lot of these things come up when a patient comes in and says, do you know about this or do you know about that? In alcohol treatment, the way that came up with, someone came in and said, do you know about naltrexone being used to treat alcohol? Did you know that alcohol could be safely tapered off by a lot of patients using something called the Sinclair method and pharmacological, they call it pharmacological extinction, which is the technical name for the Sinclair method. It's something I didn't know about early on because they don't teach about stuff. They don't teach in medical school about how to do that. But I did my research and took it further, and then joined an association and learned a lot more about it, and got to practice and get experience. Same thing with the benzodiazepines. At some point, a woman called and she said, do you know what the Ashton Manual is? And I said, no, I'm going to go look it up. And I don't think I talked to that particular woman again. I think that was our only conversation, but that sparked my interest. And benzodiazepines are everywhere. I mean, I have family members who take them or have taken them. It's been prescribed to me in the past. I mean, they're prescribed at probably a lot of people going through medical school. It's a very it's a lot of anxiety and medical training and in the health profession. I remember being at the desk of, in a hospital. I was writing orders on a chart, and there was just a lot going on at the nurse's station. And the nurse just said really loudly, "I wish I had a Xanax right now." And everybody was just quiet because that just wasn't the right thing to say at the nurse's station. But they're just everywhere. I mean, it's just part of society. And, I've seen people go through it. So it was something I became very interested in. And I saw how it fit in with my current practice, even though and that's important, very important to people, for people to realize, is that almost all benzodiazepine issues are not addiction related. It's not an addiction. Putting someone in rehab because they can't get off of Xanax or Klonopin or Valium is not the right thing to do. It would be nice. That's a whole nother conversation. It would be nice if there was a kind of a rehab or retreat that was designed to help people with that tapering and withdrawal process. But it's not addiction. So it's not something that you can have people pray away or put them in an AA meeting and have them identify as an alcoholic or an addict because they're going through a physical withdrawal problem. But even though they are two separate things, there's a lot in common with the work I do, because getting people off of opioids usually involves putting them on a medication, usually buprenorphine, which does have its own withdrawal syndrome. There is a tapering process, and then helping people deal with the withdrawal after treatment. And that medication is life-saving. So it's not something to avoid, not something to withhold because of the physical dependence. But the process of helping people taper and realizing that tapering is a long, slow process is very similar. So that kind of sparked my interest also in wanting to get involved and learn more about it. But also because we had more patients contacting us asking about that, and if we could help.
Okay. So then once you sort of became self-taught and learned about it and did it with some patients, then you felt like, okay, I should start offering this as an outpatient service to people on top of what you were already offering.
Yeah, we already had patients that we were helping through this through the withdrawal process, and yeah, and I was learning the differences. I mean, there's also differences between someone coming off of alcohol versus someone coming off of opioids, where there's a lot of similarities, but very key differences. And same thing with the benzodiazepines. So after having some significant experience and time working with patients, I started writing about it. One patient brought that up. She said, it was very difficult for her to find me. She found me by being referred by somebody else, somebody that offered a fast detox where they promised they could get her off of her benzodiazepines very quickly within a week by using some kind of IV therapy. And she knew that wasn't right. So when she asked about, longer withdrawal tapering process, they recommended me, and she came to me. And then she said, during treatment, she said, well, I had a lot of trouble finding people. I looked people up and you weren't out there. So I started writing articles for my website. I wrote a couple of articles that just in hopes that Google would rank them and that people would start seeing them. And then I think we did the press release, and now I think you guys have listed me on a website. So yeah, so we
Yeah,
just
Benzo Info Coalition, you mean? At Benzodiazepine Information Coalition, we listed you. Yeah.
yeah, and I think a big part of it for doctors that are thinking of getting involved in this is that you can learn about it. That the website benzoinfo.com has a lot of information. Was that the one that you just said, or was it a different one?
Yeah, that's it.
Yeah. Okay, sorry. Yeah, benzoinfo.com. I have it open in front of me right now. There's just tons of information. I'm even seeing things there that I didn't even realize I want to go back and read. So, doctors could just keep this open on their desktop and just browse through it in their free time. And I think the key thing is that if speaking to doctors, if you're going to see patients and help them through this process, it can be very slow and long term, and it's at the patient's own pace and what they're comfortable with, which again is also similar to addiction treatment, where some addiction doctors tell a patient, this is what we're doing now. Now it's time to taper off. Now it's time to stop your medication. But the proper way to do it is that it should be patient initiated. It should be when a patient is ready to take that next step down. And if they're not ready, then it's not time yet. And another thing that's important is to make the time to listen to patients, to listen carefully to what they have to say. And one great thing about seeing patients is that one patient can teach you a lot about how you can help the next patient. People have tried all kinds of different things and they find what works for them. And then you build a whole new library of resources of things that are useful. You know, what can help a person to get to sleep without using other medications? What can help a person to relax? There's just tons of great things that not only can we learn from places like benzoinfo.com, but also just from experience with just taking the time to listen and talk to people.
Yeah. Amen to that, really. Um, so you had myself and Lynn on your podcast, and during that conversation, you mentioned something that you already mentioned in this conversation, actually, about how um, most cases that you see of people on benzodiazepines is physical addiction. I'm sorry, physical dependence and not addiction. And you make the distinction, which is huge. There's so many people who misunderstand this problem with benzodiazepines as an addiction problem, and it can really lead to mistreatment of the patient and more harm. So for people who don't know, who are listening, can you explain a little bit better what the difference between physical dependence and addiction is, and why you make the distinction, why it's so important for people to understand they're so different?
Yeah, first of all, addiction um, is an addiction is kind of more of a layperson's term. It's not really something that psychiatrists and mental health providers typically use. They talk about use disorders and very specific ones like opioid use disorder, alcohol use disorder. Um, but addiction is characterized by a person having obsessions over their drug of choice. You know, they have cravings. You know, they think about it all the time. They have the compulsion to keep going. You know, someone who has a drink of alcohol, they can't help themselves. They just keep going to the point of excess where they harm themselves. So it's characterized by cravings or obsessions, compulsion to keep going, um, relapse, you know, where they stop using their drug of choice and they have some time drug free, and then they may relapse for no special reason, or maybe some small thing triggers them and they go back to drug use and then they come off of it again, hopefully. Um, it, you know, so that, and it's self-harm, you know, so you see you're harming yourself and you can't stop. Um, a person could be crying for help and then lying to cover up their addiction at the same time. And even though the lying is part of addiction, it doesn't mean the person's a bad person. It's not a moral deficiency. It's really a mental health issue. And people that lie to cover up their addiction don't often always lie about everything. They're just lying to be able to keep the drug use going. You know, and once they're ready to get help, you know, you can usually trust that they're going to tell you the truth about a lot of things. But that's addiction. Physical dependence, and sometimes it can be confusing because it can be physical dependence on a in the brain, you know, on a microscopic scale. You know, it can be, you know, there's receptors involved and maybe of a downgrading or upgrading of receptors, and so it's happening in the brain. So people think, well, if it's in the brain, how is it physical? Well, the brain is a physical organ, and when the brain gets used to something and then you suddenly take it away, there's physical symptoms. Um, and there are a lot of drugs that have physical dependence. Um, they cause physical dependence, but they don't cause addiction. An example is beta blockers, which are heart medications or blood pressure medication. If a person takes a beta blocker for a long time and they suddenly stop taking it, they become physically sick. Their heart starts racing. They have a rebound tachycardia, fast heart rate, and that's physical dependence. They're physically dependent on that drug that has no effect on the brain whatsoever. You know, they're not addicted to it. Um, you know, people become dependent on all kinds of different medications and things that if you take the thing away too quickly and don't let the body adjust to going back to like letting the receptors upgrade again, getting back to normal, then there's so with the benzodiazepines, a person could be addicted to a benzodiazepine. It's very rare. It's unusual. I think I've met one person that I can think of that um, he used to get a prescription from me for Xanax, and this is going back like probably 20 years. And he came in one day and he was getting like 90 Xanax a month. I forgot what strength, but he said, came in one day and he said, you know, I'm very sorry. I was addicted to Xanax. I was really abusing it. And I just want to let you know so you don't give me another prescription. And I apologized to him. I said, I'm really sorry. If I had known, I would never have given you the prescription in the first place. And he laughed and he said, that wasn't your fault, really. You don't know how much I was using. What you gave me for a month, I was using in a day. And yeah, that kind of shocked me. He's like taking 90. I don't know if they were 0.5 or 1 milligram, but he was taking huge amounts of it. That's somebody who's using it addictively. And even then, I don't know what was behind it. If he was, he said he had anger issues. So I guess he was self-treating something else. But that was really unusual. Most people, it's a physical dependence issue. And something I think we talked about on the other podcast is that even the federal government understands it's not something with a high abuse potential. The benzodiazepines are Schedule 4, putting them at a lower abuse potential than opioids and Tylenol with codeine, and a whole bunch of things are considered to have a much higher abuse potential and addiction potential.
Is it true though, in the addiction world, I guess, that when you see people abusing, because even abuse and misuse is not addiction by definition, you can abuse a medication and not be addicted to it. The people who are abusing benzodiazepines, are they doing so like in combination with other drug use so they can like come down off of something, or how are you seeing it?
Yeah, in that case, that guy was probably an anomaly, and there's probably more to the story. And there can be situations where a person is addicted to one drug and they can't get that drug, so they abuse whatever's around, whether it's cough syrup or Xanax or Klonopin or whatever, whatever they can find in the medicine cabinet that's going to change their state of mind or the way they feel. So, and they're going to tend to use that thing addictively. So yeah, someone could have cocaine use disorder or whatever they call it, stimulant disorder, use disorder, and then they may have a run where they get, they seem like they're using a benzodiazepine addictively, but that's not their drug of choice, and they can probably stop that fairly easily. And if you were to put their drug of choice and a benzodiazepine in front of them, they would just take the drug of choice. If they're opioid dependent or opiate addicted, they would take the opioid and leave the Xanax behind, or the benzodiazepine. There is a thing where Xanax particularly has a street recognition. People talk about the bars. They call them Xanax bars or Xanny bars, and I think some of the drug dealers, like the cocaine dealers, will give them out with the cocaine because it helps take people down from when they're like up for days at a time. So yeah, and also I think alprazolam or Xanax is the number one secondary drug of overdose, which I think means that it didn't cause the overdose, but it's the most common drug found secondary to the drug that did cause it. So when someone dies of a cocaine or opioid overdose or alcohol overdose, the most common drug to find in their system, in addition to the thing that caused it, is alprazolam, giving it a bad reputation. But and it should have a bad reputation. It is something that we don't want to promote or tell people they should take, but it's not really that addictive.
So the misunderstanding of this important distinction between addiction and physical dependence, do you think that is why when patients come into most doctors' offices, doctors, and say like, I can't get off this stuff, or I'm having withdrawal, that the doctors, say, oh my gosh, well, I'm cutting you off of it, or I'm not writing any more prescriptions for it, or you're going to rehab. They just don't understand what they're seeing, essentially.
Yeah, I've heard all kinds of things. I talked to a doctor that was very proud of the fact that he had figured out a way to deal with patients that came to him on benzodiazepines, and he was doing pain management, and he didn't want to prescribe opioids with benzodiazepines. So if a patient came in on both, his solution was to immediately put them on anti-seizure medication. I think Keppra was the one that he recommended. And he was really excited that he'd figured out that Keppra could be the alternative. And I don't know what the outcome of that was, but it couldn't have been good. Probably maybe those patients went and found a psychiatrist, or maybe they didn't continue seeing him when he did that. But yeah, there's a lot of misunderstandings in doctors trying to figure out ways to deal with it. But that's pretty common. Doctors often will mix up and confuse physical dependence and addiction. And there's even pseudo-addiction, where a person is mistreated pharmacologically, and then they look to the doctor as if they're some kind of a junkie, and then the doctor will look at them and say, oh, you're addicted. And could be that they're undertreated or they're not being treated properly, but they just have like an appearance that to the doctor looks like they're addicted, and they just call them an addict. And an addict is not a good term, even for people that do have an addiction problem. It's kind of a negative term to call someone.
Right. Okay. So with the pseudo addiction thing with benzodiazepines, would that look like maybe somebody's been taking the same dose of benzos for a year? All of a sudden, they are in tolerance withdrawal from the benzodiazepine, and the tolerance withdrawal sort of looks like addiction because they're in withdrawal, but they're still taking a steady dose of benzo. So they're asking for more, or maybe they're even increasing the
Yeah.
dose on their own.
I think it could be used in that situation. I think mostly pseudo addiction is thought of as a person with chronic pain is treated with opioids and they're not given the right dosage, or their dosage is cut back. And then when they're in more pain and they go and ask the doctor for more opioids and tell them it's not working, that's where it's traditionally used. But I think the term could very well be applied to benzodiazepines in the same exact situation. In fact, a lot of people, that's a good point to make. A lot of people that go for pain management and get opioids prescribed to them are not addicted. They're physically dependent. Not, in fact, addiction may, there's a lot of controversy over how many people that go for pain management and get opioids become addicted. Purdue had told us it was a tiny percentage. They said it's like less than, a fraction of a percent, where really, realistically, it could be, we don't really know, but it might be 5 to 15%. But that leaves like a whole 85+% of people that go for medical pain management that are probably not addicted to those medications, but they're physically dependent. So yeah, same thing with it. I think that pseudo addiction could very well be applied to benzodiazepine reactions to tolerance and any issues where a patient might appear to be addicted to the doctor.
Yeah. Okay. So previously, you brought up the fact that a patient said to you, "Hey, have you heard of the Ashton Manual?" And you went and looked it up. And for anybody in benzodiazepine withdrawal, that's sort of like the Bible of benzos, even though I think it's from the 90s when she first put it out. So we'll put a link to the Ashton Manual in the comments for anyone who's never referenced it. But after reading it and working with patients, have you found problems with the Ashton Manual, or things that you've like improved upon her suggestions since doing this yourself and working with patients?
Yeah, the Ashton Manual is a great solution to benzodiazepine physical dependence. And yeah, she really came up with a great way to, and ideally, when these resources are available, if I had a clinic where I had, bottles of Valium and all kinds of different benzodiazepines, or really you just need Valium because the person may already have a prescription for the thing, because the way it works is that a person is transitioned gradually. If they have multiple daily doses, say they take their benzodiazepine 3 times a day, you would gradually introduce it. Like you might change like the evening dose or the midday dose, and then little by little you transition over to Valium. And the benefit of Valium is it's one of the weaker benzodiazepines, and it's fairly weak compared to the other ones. So like, for example, Xanax 0.5 is equal to 10 milligrams of Valium, or Klonopin 0.5, or Ativan 1 milligram is equal to 10 milligrams of Valium. So now you're using a less potent drug, and it has a very long half-life, so it doesn't wear off quickly, so you don't get the intradose withdrawal, like where Xanax lasts for a very short time. So if you take 2 Xanax a day, maybe even 3 a day, in between doses, a person may feel withdrawal symptoms. So the Valium is longer lasting. It's weaker. It's not as potent. So now, and they make 2 milligram tablets. So imagine a person's on 0.5 of Xanax and they switch over to 3 times a day, and they switch over to Valium 10 milligrams 3 times a day. Now you can use those little 2 milligram tablets, or maybe 5 milligrams or 2 milligrams, and you can just gradually taper down without, for the most part, most of that time, you don't have to worry about breaking tablets in half, until maybe you get down to the end with 2 milligram tablets, and then maybe break them in half. But so you can taper down to a very low amount with using Valium tablets. But realistically, in the real world, giving someone a prescription for Valium, and maybe they need a refill of, say, their Klonopin or their Xanax because they haven't transitioned yet, and now they go to the pharmacy with 2 different benzodiazepines. That's a red flag for the pharmacist. So that's one issue. Also, a lot of patients find that Valium, they're just not comfortable with it. They've been comfortable with one drug, Klonopin or Xanax or Ativan or whatever it is, for a long time, and now we're switching them to Valium, which they're not really, may not feel the same or work the same. And So I think it really is great to be able to help someone taper on the medication they're already on.
Mhm.
And I think we did talk about that in the other podcast, where that's where a compound pharmacist can become the partner, a really useful partner in the treatment of benzodiazepine withdrawal or the tapering process. Um, a compound pharmacist is a pharmacist who can make custom preparations where, instead of saying, like say you go to a regular pharmacist and you say, well, what kinds of Klonopin do you have here? Well, we have a 0.5, a 1, and a 2, and that's all we have. And then
Mhm.
you say, well, I'm on the 0.5, I want to taper. What can I do? The regular pharmacist says, well, your doctor can tell you to break the tablets in half, crush them up or whatever. And, now you don't really have a workable solution. So that's where the Ashton Manual was useful with the regular pharmacies. But if a person can go to a compound pharmacist, they can make smaller amounts. You can, in fact, say, well, this is my tapering plan. I'm going to taper by 5% every 2 weeks. A really good compound pharmacist will formulate that and do the calculations and even work with the doctor and say, this is our plan. And you can go in and get like custom made capsules that have just the right amount for each week along the way. Or they can make a liquid solution where it can be measured out with a syringe, where you could have, for example, 0.5 of Klonopin or 0.25 of Xanax mixed in with a 10 milliliter syringe, or 10 milliliters per that, 0.5. So just say, for example, Klonopin 0.5 milligrams and 10 milliliters. And so now 10 milliliters, so 1 milliliter would be a tenth of that. So you can taper by reducing, for example, 1 milliliter per week or every 2 weeks. You can come up with a very workable gradual tapering plan as the patient can tolerate it. And you don't have to worry about mixing different things and you're tapering on the drug the patient's used to.
Yeah. Okay. So I think I saw on your website somewhere where you also have a conversation with patients who they don't fully want to come off, but maybe they want to reduce the medication. I think in addiction medicine, that's called like harm reduction, just getting somebody on the lowest dose possible. But I'm curious, how does that work with benzodiazepines that carry, the risk of tolerance? Can you get people down to a lower dose and then just leave them there?
Well, harm reduction is more useful in the world of addiction.
Mhm.
Um, in the U.S., addiction treatment is very tied up with Alcoholics Anonymous. Alcoholics Anonymous was founded in 1935 and has been there throughout the entire development of the rehab industry and addiction treatment. In fact, if you look at one of the major groups that credentials doctors and makes them board certified in addiction medicine, they strongly recommend the 12 steps. And there's something called 12-step facilitation. When you go to rehab, they indoctrinate people with the 12 steps and they bring them to meetings during rehab. Um, and the 12-step philosophy is in favor of abstinence, of coming off of all drugs and kind of just dealing with the withdrawal. And if you're and so their ideal is like you go to a meeting or you go to a rehab and they take you off of everything, or they take you off all the addictive bad stuff, whether it's alcohol, cocaine, opioids, or benzos, benzodiazepines. If a person accidentally, say that their family says you're addicted, you need to go to AA or you need to go to rehab, and they, maybe they don't know the difference between physical dependence and addiction. So now a person misinterprets their own condition. They think they have addiction. So they go to rehab and they're told, well, we're taking you off of everything right now. That Xanax has to go. You're coming off of it. You might feel sick, but you need to pray and work your steps and go to meetings every day and meet friends who have gone through alcoholism and cocaine addiction. All these people that have gone through every other kind of drug addiction. You have the same thing they have, and so that's what they tell them. And so I forgot the initial. What was the original question? Sorry, I went off on a.
No, it's okay. Harm reduction. And can
Yeah,
people actually stay on a benzo, even a lower dose
yeah.
without
So
like a
that's what.
tolerance? Yeah.
Yeah, so that's what it is. Yeah, so harm reduction is is there because that whole thing I was talking about, whether it's for addiction or benzos or whatever, that whole thing does not have a very good success rate. Rehab and AA have a success rate that's probably 10% or less. It may even be as low as 1%, depending on how you study it. It's hard to study, but we know that, and there's a survivorship bias when you walk into an AA meeting and everybody in there has decades of clean time, and you're like, wow, this works really well. But you don't see the thousands of people that walked in and walked out and didn't make it, or it didn't work for them. So the thing is, there's a lot of people who are not ready to give up an addiction. And so harm reduction is really about protecting them, keeping them safe until they're ready to get help. Harm reduction would be like what they do in Canada. They provide a safe supply. Doctors are allowed to prescribe opioids to opioid addicted people, so they don't have to use stuff on the streets like, fentanyl analogs from China that may kill them. And now they know what they're getting. They know the strength of what they're getting. One of my podcast guests, David Poses, had a great saying. He said that the alcohol is not safe. It's not legal because it's safe. It's safe because it's legal. Because when you drink a drink, you know how much you're getting. You know that you don't have to worry that you're going to have a drink of beer and suddenly it's 1,000 times more potent than what you were expecting, and it knocks you out. So that's, when things are legal and things are made available, that's harm reduction, giving people clean needles or clean stuff so they don't have to worry about getting deadly infections, or giving people a known safe drug to use. The Sinclair method for alcohol is kind of considered to be harm reduction, because the AA ideal is go to a meeting and stop drinking. And then what happens is they have cravings later on, like months later, they have alcohol deprivation syndrome because they didn't taper off gradually. They had to stop suddenly. But by giving someone naltrexone with alcohol, which is a Sinclair method, basically you can describe it in one sentence. Take naltrexone, have your one drink an hour later, and it makes it possible that they can taper gradually. That you can call that harm reduction, because it doesn't go with the traditional. We're going to tell the person, we don't want you to drink, but if you're going to drink, take this medication. I don't know if you can apply harm reduction really to the benzos, because it's more of an addiction thing. People that are in the pre-contemplation stage of addiction, they're not ready to give up their drug of choice yet. But yeah, benzodiazepine, a person might say, I guess you could apply it in the sense where a person is prescribed benzodiazepines and they're taking a high dose, and a doctor can have the conversation. And that's something I've encouraged a lot. I may have a patient that's been on benzodiazepines for years, and they're comfortable with it. It works for them. And maybe they're not one of these people that needs to come off of it. There's percentages of people that don't have a problem with them. But I've started to have the conversation with anybody I come across. Maybe think about it. Think about tapering. Think that maybe you could be on less. Maybe you don't need 1 milligrams 3 times a day. Maybe 0.5 3 times a day, or maybe you only need like a fraction of that. I think that could be the harm reduction for benzodiazepine dependence, physical dependence, is to just start having those conversations with people about maybe less is better, and then eventually maybe none is better than anything.
Mm-hmm. So you mentioned these rehab places and how people misinterpret what's happening with somebody. And that's exactly what happened to me when I was on benzodiazepines and physically dependent. I didn't know where to get help. I knew I wanted to come off once I realized what the problem was. And everyone misunderstood and said, oh, you just have to go to one of these rehab places. So I remember thinking, like, this is bizarre. Does everyone whose doctor prescribes them Klonopin, then you have to go to a rehab to get off of it, but I was so sick from it and desperate that I went to one of those places. And it was a horrific withdrawal syndrome that they put me through. But one of the things that they did also was they take you off of everything they deem addictive, right? So everything that has like a scheduled drug. So the benzos have to go, the sleeping pills have to go, Adderall has to go. But then they load you up on all these other psychiatric medications that later, to me, when I analyzed it in my own mind, I was like, this is so silly, because now I'm on all these other psychiatric medications that also cause physical dependence and withdrawal syndromes, like antidepressants and things. So it's like I just got a new problem, and they didn't really solve the problem that I went in for. So do you typically see this when people are coming out of these rehab centers, that they are being loaded up on more and more psychiatric drugs just to sort of like cover up withdrawal syndromes from other substances?
Yeah. There was a time early on when I started doing addiction treatment as a major part of my practice that I was getting phone calls from people that ran sober home facilities and things like that. And and they would ask, can you come see our patients? Not we, and they were very anti-Suboxone, which is funny because Suboxone is a incredible life-saving drug that saves a lot of lives and helps people to be functional for a period of time while they're taking it. And but they're very much in favor of people getting all kinds of what they call non-controlled drugs. They say, please come in and prescribe the non-controlled drugs that all of our residents are taking. And they would want me to come in once a month or whatever and do rounds and see everybody and take a list of what they're taking. And they were mostly psych drugs. They were antidepressants, things like gabapentin, just, but yeah, no controlled drugs. I mean, yeah, I mean, there really should be maybe like a different kind of control, maybe not the DEA where they're after street abuse and diversion, but maybe like an awareness of that we don't really know what these drugs are doing to people's brains, and we don't know if they're doing anything beneficial for a lot of people. I mean, in some cases they may be. There may be people that really benefit from an antidepressant or antipsychotic drug, that has a really serious mental health issue. But and there's another thing I noticed when early on I did a psychiatry rotation as a student, and I was in this facility where they called everybody dual diagnosed. They said everyone here has a dual diagnosis, and I asked what that meant, and they said, well, they all have addiction to something, but they also have an additional mental health diagnosis. And right away, I thought, like, that's some kind of insurance billing scheme. Call everybody, because you can't. Maybe their insurance won't cover addiction, but it'll cover mental health. So if you say, like, they're addicted, but they're depressed or they're anxious or they're whatever, they're psychotic, and how can you really tell what a person has when they're coming off of drugs? I mean, a person who takes opioids or cocaine, they have all kinds of psychosis or depression or anxiety, things caused from the drug or the withdrawal from the drug. So until things clear up, you really don't know what they have. And so they might be medicating symptoms and not an actual underlying condition. And maybe it really is an insurance billing scheme in some places. I don't know. But yeah, that definitely is an issue in facilities of people being put on psych drugs where maybe they should have waited to see, what's really going on with them.
Yeah. Okay. So when your patients are tapering benzodiazepines, the ones that you've worked with, what kind of symptoms do they present with?
Oh, during the tapering process?
Yeah. What are you seeing?
Yeah, insomnia, not being able to sleep is a big one. The gastrointestinal symptoms seem to be fairly common, what they call the benzo belly, and headaches and just kind of feeling out of it and disconnected. I guess I know there's a term for that. I always forget it. It's like
like depersonalization and derealization.
That's it. Yeah. That I think that's pretty common. People feeling like they're not in their own body, or they're like their life is like they're watching things from the outside, or they feel disconnected from things. That's pretty common. And rebound anxiety. But yeah, I think those are some of the most common things that I'm seeing.
Okay. And then what about protracted issues post withdrawal? Have you had any patients with severe protracted problems?
On and off, and some people describe I would say at 30 days is kind of a milestone for a lot of people of, going from the drop off, what we call the drop off of you take your very last dose, and then, a week in, you should feel somewhat better. 2 weeks in, hopefully, hopefully at some point you're getting some decent sleep, and there's all kinds of different things from the different sound therapies that can help. And one patient strongly recommended this grounded mat that I've been meaning to try myself, that she says gives her incredible sleep. She found a thing on Amazon. It's not even that expensive, and it's like a mat that you connect a thing to the ground. You're actually grounding yourself like you would an electronic piece of equipment. And but yeah, there's all kinds of. But yeah, insomnia is a big thing. Anxiety, pain. That's another one. I guess through the whole process, there can be aching, back pain, foot pain. Just and then more anxiety. But it seems like at 30 days, there's like that's a milestone where a person can look back and say, wow, things have significantly improved since that day that they took the very last dose.
Mhm.
And then going forward, 60 days and 90 days are big milestones where there's even further improvement. But yeah, the symptoms can come and go. So, a person shouldn't feel like they've gone backwards, or that things aren't working. If they suddenly have a reoccurrence, say 2 months down the road, they start feeling, that depersonalization, or like other symptoms start coming back, or the gastrointestinal upset. But that's another important point to make. Um, should doctors tell people like, oh, that's just the withdrawal you're going through, or is it something else we need to look into? I mean, there is always the possibility that something new came up, and at that point, a lot of people don't really trust doctors anymore. Once
Mhm.
they've come off of benzodiazepines, they feel like doctors got them into this situation, and now they don't really want to trust a doctor. But it's still important to do things like colonoscopies when they're due, and mammograms, and other kinds of blood testing routinely. It's still important to get like a yearly physical and check out symptoms. And sometimes if those symptoms do persist, it's good just to be on the safe side, and make sure that, is there an issue? Is there a thyroid issue? Is there a blood sugar issue,
Mhm.
electrolytes or whatever? So it's important to still treat the patient like a patient, and consider the possibility that there could be something else going on. But, usually those symptoms, it's good to be aware of them, that those are typical benzodiazepine withdrawal symptoms.
Mhm. But so, I mean, typically your patients are improving pretty quickly then. You don't have any like long-termers that have been suffering from withdrawal for like 3, 5, 7 years post cessation.
So far, I haven't had any, and I've had patients that were on benzodiazepines for many years, but
Mhm.
I have not personally. I've read accounts of them. I mean, there's a lot of course, on social media. There's people talking about it in the different groups where they talk about um, having, and yeah, I mean, a person could have very long term, like that feeling of being disconnected from reality, of the derealization. That could be something that a person might have for many years, and they just get used to it.
Mhm.
They get used to living their life with it. So it's hard to say. I mean, there could be lingering, lasting symptoms, but I haven't really had a person who long term just didn't feel any better. It felt like the symptoms were the same intensity over, many months or years.
Okay.
Although I can imagine that there are plenty of people out there that do have long lasting symptoms. I'd recently interviewed Dr. Christy Huff, who's very involved with the Benzodiazepine Information Coalition, and I think she had talked about, she's publicly open about how I think she's been off completely for 3 years now, and
Mhm.
she had said in our talk that she pretty much feels normal now 3 years later. So it sounds like a long time, but um, that I'm sure that wasn't all at once. I'm sure it wasn't like things were intense and then suddenly at 3 years it just stopped. I mean, little by little you feel better, and I mean, people should have hope for improvement. That, and kind of think positively. And there's a lot of things a person can do to promote improvement and feeling better about how they feel.
Okay. So I wonder, as an addiction specialist, are you frustrated that, um, these issues are caused by primary care physicians and psychiatrists with benzodiazepines? And then when these people are all caught up in the cobweb of benzodiazepine physical dependence, and it just falls on your lap to sort of clean up the mess that was made. Or not,
I
maybe
just
not your lap, but like in the lap of addiction, the specialty of addiction medicine.
I think that a lot of those doctors just don't know any better. I think a lot of us really just didn't realize what was happening. But
Mhm.
benzodiazepines seem very safe because they tend not to kill people. Um, if a person only takes a benzodiazepine and they take it for years, or they take too much of it, most people are not going to overdose and die from, even if they take a lot of it. I mean, it's not like opioids where we have an opioid epidemic and people are dying and there's overdoses, and it's like a war. You're counting how many people passed away caused by the drug overdoses, and that's just not happening with the benzodiazepine
Mhm.
problem. I mean, when you look at some tragic event, they say, this many people died and this many people were injured, and the injured people are like, well, at least they survived. But with the benzodiazepine epidemic, it's all pretty much all injured people, And so we need to look at that more seriously and say, well, what are these injuries that people are sustaining and what can we do about it? But I just think that the doctors don't really know what's that. I used to think psychiatrists were just experts and we could kind of defer to their expertise, that they know what they're doing with the benzodiazepines. I saw a psychiatrist prescribing like two at once to a patient, and it wasn't Valium. I don't think he was doing the Ashton method. I think it was probably like Restoril and Xanax or Klonopin and Xanax. It was two things that just didn't look right together. And I thought like, oh, maybe there's some weird thing going on. I thought I better notify him. Maybe the patient called in their own prescription or something. So I called and talked to a secretary, and she looked in the chart and she said, no, that's correct. That's what the patient should be on. And I was always under the impression from reading in one of the prescribing manuals that primary care doctors had a limit for like Xanax, that they could prescribe an absolute maximum of like 4 milligrams a day, where psychiatrists were allowed to go up to 12 milligrams a day. And that was some difference, that they magically had additional knowledge that they knew when they were allowed to do that.
Right.
And now I'm starting to think like they don't really know much more than we do about all this stuff.
Yeah.
That they're just kind of like, I mean, they have some complex criteria for picking drugs of like, this is the best in this category and that's the best in that one. But in the end, I don't think that they really know any more than anyone else what they're doing to people by keeping them long term on these medications.
Yeah. Yeah. We interviewed a clinical pharmacologist once, and he was like, the psychiatrist and, doctors in general, they don't have the training in pharmacology like a clinical pharmacologist does on, the medication super in depth. And so I think he would agree with what you said, that they probably don't know everything that they could, or most of them anyways, about the benzodiazepines. So I guess let's move into informed consent then. If we're going to still use benzodiazepines, well, first of all, how should they be used? Like in an ideal world, what's the best way to use them? And then what should patients be told who are considering taking them? And what should patients who are considering coming off of them be informed about?
Well, I think we could look at it the same way that we're looking at opioids now, that we should look for other things, things that are non-medication related, and not using medications, not throwing a prescription at everything. Ways that people can relax and deal with anxiety, where maybe we don't start anything, not even a low dose of something, because a low dose turns into tolerance, which turns into a higher dose. And and there are other medications that may be safer for short-term use. But where are the benzodiazepines useful? I used to think they were useful in surgeries for like one-time surgeries, because they used to use Versed for a lot of surgeries, like for colonoscopies, they were pretty commonly, it was used. And it seemed great because a person could be awake for the colonoscopy, so the doctor could say, turn this way or turn that way. And because of the amnesic effect, the patient would have no memory of what happened. So that was a good thing. But it seems like they can use propofol for that now. Like, it seems like they're using propofol for a lot more stuff. And I don't know if there's gonna be a propofol epidemic one day. We're gonna find out there's something bad about that. But so far, it seems to be a better solution for those kind of issues. There's no need to use Versed for a lot of things that we thought it had to be used for. So where are they useful? I mean, if a person absolutely can't function and you can't give them any alternatives, like you can't even have the conversation. If I tell someone, let's talk about meditation, let's talk about sound therapy and relaxation and being aware of your surroundings, and I could give a person can't even hear me because they're so caught up in their anxiety. Maybe there is like a certain cutoff where at this point we'll use medication but plan for short term, and then as we're tapering it down or keeping it at a low level, then we can have those conversations when the person's able to listen. Kind of similar to treating opioid dependence, where we use medication because the person just really can't even hear us at a certain point, and we can't even really start talking about recovery and therapy and coaching and things like that until they're able to listen. And so we put them on medication, and then they can listen, and then we start talking about, this is how long the medication will last for, and we'll be tapering all along the way. So there probably is a place for benzodiazepines. Just I think it's similar to like when they medicate children with ADD medications. I mean, I think there was a time when teachers could actually prescribe the medications indirectly. They could say, I'm not allowing this kid back in my class without, some kind of Adderall or whatever the other ones are that they give kids for ADD. And now I think we realize that a lot of those kids, maybe their needs aren't being met in school. Maybe they need to be challenged more, or maybe they need better teachers teachers that aren't babysitters, that don't want to just sedate the kids or medicate them. So maybe the kids don't have a problem, the teachers and the schools have a problem, but there probably are some kids that need those medications that really just can't function without them, at least for a period of time. So maybe it's just a matter of using them just a lot less. And but yeah, informed consent is very important to tell a person, when you start this, you may have a lot of trouble coming off of it. That was in the movie, and Medicating Normal, that doctor that was saying, well, I told you all this stuff when you got started, and the patient said, no, you never told me this stuff. And he should have told her, and hopefully he did. Maybe she wasn't listening if he did. I mean, I don't really know that, but and maybe, doctors put things in writings, they have contracts, they say, sign this paper, here's a bunch of fine print. I've been through that in doctors. I've gone into a doctor's office and I just want to see the doctor, and they give me pages of stuff and I sign it. And then later on they send me a bill and I'm like, well, I thought I paid for everything in the office. They're like, oh, the fine print said we can bill you later for more stuff. So yeah, I think patients that just want to get treatment and they're not feeling well may sign those papers without reading them, or they may say to the doctor, look at this all these terrible things that can happen if I take benzodiazepines. And the doctor says, well, I don't really see that stuff. Most of my patients just stay on them permanently and they do fine with them. I mean, so, maybe the written informed consent is important, the verbal informed consent, but really a whole change of thinking of the doctor really being in favor of trying different things and working with the patient and seeing, like, are you willing to try these other options of meditation, yoga, walking, fresh air, maybe consider changing your job, work on your relationship. I mean, there's just, maybe addressing the actual problem that's being medicated.
Yeah, those are all good points. In the podcast where Lynn and I came on to talk to you, you mentioned something, you thought that doctors are sometimes gaslit, and that maybe sometimes medical providers are victims in this problem too. So, because a lot of patients are angry when they are made physically dependent to benzodiazepines, and then they have to go through this horrible withdrawal syndrome and they weren't aware of it, and they're pissed, and rightfully so. But how do you think the doctors are victims as well, or gaslit in some instances?
Yeah, and with the prescribing of benzodiazepines, maybe not as much, because I mean, these drugs have been generic for a long time, so there's not really a big evil pharmaceutical company behind them. And that does happen. There's doctors, the whole medical education system is infiltrated by the pharmaceutical companies. So, and we're seeing that now. They have that movie online somewhere about Purdue and what Purdue did. I haven't watched it, but I know just from my experience, because I graduated medical school and started my residency, my first years of work during the time when Purdue really started influencing doctors of prescribing more opioids. And I remember from 1 month to the next, when the rep came in and talked to us about how OxyContin can now be used for chronic pain and not just cancer patients. And that was my first thought, like, wow, what a great business model. Now they're not just giving it to people that are terminal, they're giving it to people that could be on it for years. And I think a lot of these drugs are designed for permanent use. Even benzodiazepines, they don't really make enough dosage levels and forms of it for people to taper off safely. And that's for a lot of different things, not just the benzodiazepines. But yeah, the gaslighting is probably more of like, yeah, the pharmaceutical industry is very much tied, and they're not giving us straight information on the dangers of these drugs. And the benzodiazepines, probably, if you go years back, there's some interesting advertisements. I don't know if you've ever seen those old drug ads, how great Valium is, and it can be used for a million different things. It's the greatest drug of all time. So I'm sure at some time I guess it was Roche that made Valium, and I'm sure they were pushing it and telling doctors this is the greatest thing ever. And then that just perpetuated after. Doctors just kind of got used to that of these drugs are safe and they're great and we can use them for everything. And even though Roche doesn't care anymore, because nobody's really buying their kind of Valium anymore, but they're prescribing the generic. are filling the generic. But that initial influence of doctors of that, and that influence from the pharmaceutical companies is not just those drug reps coming in. We do have these people coming in, like these reps that are probably matched very carefully to the doctor, of like, here's someone that you're going to really communicate well with, and they show these fancy graphs of like, look how great this drug is, it's the best thing ever. But they go a lot deeper than that. There's doctors that we trust when we go to medical conferences, that like older doctors or doctors that are in authority positions. They're have a lot of credentials, and they've a lot of board certifications, and maybe they've been lecturing for years at the conferences, and they get up there and tell us how great this drug is and that we should be using more of it. That would be a kind of gaslighting of now we're like, in fact, in the case of pain management and opioids, they were telling us 20 years ago that we might lose our license if we don't prescribe enough opioids to people, that we're under treating and mistreating pain. Right. And now it's gone completely the other direction, and it's probably moving back in the other way. You may see in 10, 20 years at some point over prescribing of opioids again. But yeah, there definitely is misinformation, and the pharmaceutical industry is very much entrenched in medical education, and doctors are taught, have an exit plan, get in, see the patient, come out, write a prescription. And that, that's not medical school. They don't say that the first year of medical school, or even, but along the way, that's the education that you get when you go on rotation to go to hospitals and work in clinics. You're not allowed to sit there and talk to a patient for an hour. You're not allowed to and you're told, prescribe some of this and this will help them, or use that. It's a lot of it is pharmaceutical based, of this is a drug to help that problem.
Yeah. Okay, so I'm looking at the time. We have a couple minutes left. I guess I want to close by asking, if people are in Florida and they can get to you for help, that's awesome. And in a minute, I'll have you give your website and everything like that so people can find you. But if people aren't in Florida and they need a doctor who can help them with benzodiazepines, what advice do you have? Like, how can patients approach providers who might be ignorant about this? What should they look for in a doctor?
I would look for a doctor that takes time, that listens, that's open-minded. If you say to a doctor, have you heard of the Benzodiazepine Information Coalition? Have you heard of the Ashton Manual? Do you know about that tapering can sometimes take years coming off of a benzodiazepine? If the doctor says, oh, that's great, here's your prescription, I'll see you next month, that might not be the doctor to work with. But if the doctor says, wow, that's interesting, and they're maybe looking it up in Google right then, or they call back later and say, wow, I looked that stuff up and that really is interesting, maybe we can work on that. That might be a doctor to work with. And along the way, like I said, a doctor that when they're ready to get started, that they're willing to work with a compound pharmacy. I spoke to a man whose wife was coming off of a benzodiazepine, and he talked to his doctor about that. He said, can you work with this particular compound pharmacy to develop a tapering plan? And the doctor just said, I don't know how to write a compound prescription. That I don't know what that is. And all he had to do is maybe make a phone call to the compound pharmacist and say, I want to prescribe this, I don't know how to do it. And that's their business. Of course they're going to tell the doctor, this is how you do it. Maybe they'll even fax them a sample prescription of how it's written. And they're really not that hard to write. You could just write compound prescription. In fact, in our electronic prescribing system, there's a checkbox for compound. You go to freeform prescription. If someone's looking for it, I think I don't have it open now, but you look for freeform prescription, and there's a checkbox for compound, and the thing for is it controlled, and it's pretty easy. It's and the pharmacist will work with the doctor to help them. So really, a doctor who listens, a doctor who's open-minded, a doctor who's willing to have conversations and listen to what the patient says and take it into account, and talk about the difference between addiction and physical dependence, and realize that this is not addiction. Don't just send them to a meeting and don't take away their medication instantly because you think they're addicted. But I think there are good doctors out there. Direct primary care might be a place to look. There's doctors who do something called direct primary care, and they tend to have smaller practices, and patients, instead of using insurance, they pay a small subscription fee, and they see the doctor every month, or no, they don't have to see the doctor every month, but it's like a monthly thing. But those doctors tend to have small panels, and they're willing to talk to the patient and take more time, and they're probably more open-minded. So, doctors that have call micro practices or ideal clinics, those are some keywords to look for. But yeah, there's definitely good doctors out there.
Okay, awesome. All right. So I guess with some closing thoughts, maybe Mark, anywhere people can find you, where they can find your podcast or anything else you'd like to share before we go.
Okay. Yeah, the podcast is called The Rehab. It's the website is therehab.com, or you can search for The Rehab on your podcast app, and my picture comes up. You'll see me and you'll see the title. And you can find my practice website at drleeds.com, drleeds.com. And there's tons of blog posts and articles you can search for topics and see if you find it. If you don't see a topic that you're looking for, send me a message and ask me to write about it. I'll research it and write a new blog post about it.
And you're also on Twitter. Are you active on Twitter?
Yeah, I am. I don't have a lot of followers here. So yeah, if anyone wants to follow me, definitely I would welcome followers on Twitter.
Okay.
I'm on Instagram as the Rehab Podcast, I think is my name on there. But I'm really not that active on Instagram, but I kind of look at it sometimes. But yeah, Twitter, I'm active. And yeah, Facebook also. Facebook is a great place to learn what people are talking about. Lots of great groups. In fact, doctors who want to learn more. Not that you're going to learn how to practice medicine from Facebook, but you can see what real people and real patients are talking about and get an idea of like what their concerns are, and learn a lot from that.
Yeah. Have you been to Benzo Buddies?
I haven't looked. Too many people have told me that it was triggering for them, and it kind of almost scared me away from looking at it, but I want to look at it. So yeah, I think I've typed it in, and somehow I haven't read anything on the website yet, but I'm planning on looking at it.
Okay. Yeah, I think you have to register, I think, to read most of the stuff. But yeah, you should check it out. Just if you're in the Facebook groups, I think it's pretty similar. Just patients, explaining what they're going through and learning taper plans and supporting one another and that kind of thing. So yeah.
I made a Facebook group called Benzo Besties, and no, there's like 7 members. There's like nobody in it, but I definitely welcome people. But my goal for it, I don't know if it's ever going to take off, but my goal was to make it purely positive, to kind of try to like motivational positive, because I think that's a huge thing of like people being positive and hopeful and having hope for the future and being grateful, keeping a gratitude list and being aware of what they're grateful for and the good things in life, and not always focusing on the negative. But yeah, definitely people are welcome to join that group, and we'll see if it goes anywhere.
Okay, awesome. And then one more question. Do you only do inpatient consultations, or do you ever do virtual consultations with folks?
We do a lot of virtual, and I've also done consultations with people that don't even intend to be patients, just conversations, even if they don't have to be in Florida. That could be anywhere in the world. So yeah, I've done virtual, video, or even audio conversations with people just to discuss their options, and a lot of what we talked about here. So someone could just watch this video and get a lot of that information, but then maybe tailor to their specific situation. But yeah, I definitely do virtual and meet with people from around the country with that.
Okay, awesome. So yeah, all of your contact links and everything will be in the comments section, or if somebody's watching this on YouTube, we'll put it in the description. So I guess we'll close now. Thanks everybody for joining us for this live discussion. If you haven't seen Medicating Normal yet, go to our website at medicatingnormal.com/watch for the many ways you can see it. We're on Vimeo, Amazon. We're also airing on PBS and on the PBS app. And we're working on more platforms as we speak. Plus now the film is available on DVD. And if you're in the United States or Puerto Rico, check the events tab on our Facebook page to see more scheduled upcoming interviews like this one. Our next interview is April 19th with Dr. Margaret Heffernan on the topic of willful blindness. Lastly, if you want to support our outreach efforts to bring the film and conversations like these to communities worldwide, you can make a donation at medicatingnormal.com/donate. Thanks everybody for tuning in today. Thanks so much, Dr. Leeds, for joining us. You're a great physician. You know so much about benzodiazepines. I wish we could clone you and put one of you in every state, because there's so many desperate patients who need help with this. So I hope, that other doctors will tune in and watch this and take some of the advice that you've given and learn from you. So thank you so much for joining us. All right. Talk to you soon. Take care, everybody.